Very good morning, everyone. Massa University introduced this webinar from Faculty of Dentistry. I am Dr. Ma'an Al-Marzouk. I will be the moderator for today's webinar. Today's webinar will be about virtual surgical planning provides the ability to visualize the patient's anatomy and pathologic conditions and establish patient's reference points and simulate osteotomies and reconstruction design in advance of the surgery. Virtual surgical planning is also an ideal environment for improved communication between the patient and the surgeon. The application of 3D printing technique is widely used for repair and reconstruction in maxillofacial region. 3D models help for teaching, preoperative planning, and practicing surgical templates for accurate positioning during operation, individual implantable prostheses for repair and reconstruction the maxillofacial bone defect. Today's webinar will deal with the application of 3D technology in dental and CranioMaxillofacial surgery. I would like to introduce Associate Professor Dr. G.P. Kumar. He is the head of Department of Oral and Maxillofacial Surgery in Faculty of Dentistry at Massa University to introduce our today's speakers. Please, Dr. Kumar.
Yeah, thanks, Dr. Mon. A warm good morning to everyone. So welcome to this live webinar organized by the Faculty of Dentistry, Massa University. So today for today's webinar, we have two eminent experts in the field of oral and maxillofacial surgery. So the first speaker is Professor Dr. Shanmuga Sundaram, who is currently a professor in SRM Dental College, Ramapuram since 2014. He obtained his bachelor's degree in 1996 and master's in oral and maxillofacial surgery in the year 2001 from the same university, the Dr. MGR Medical University. He is also a fellow of Indian Board of Oral and Maxillofacial Surgeons, and he got his fellowship in 2011. And he's also a fellow of AO CranioMaxillofacial Surgery since 2014. He has published more than 20 international and national publications, and he's also a reviewer for well-reputable and oral and maxillofacial journals. Professor Dr. Shanmuga Sundaram has delivered multiple guest lectures and live surgical demonstrations. And more than that, he's a good friend of mine. And before being myself as a surgeon, he was my consultant to my clinic. And I take this opportunity to welcome Professor Dr. Shanmuga Sundaram for this live webinar. The second speaker for this lecture is Dr. John Nissan, who is an enthusiastic surgeon who is completed his maxillofacial surgery from Sri Ramachandra Dental College in the year 2018. He did his undergraduation from Dr. Dental College, Chennai in the year 1997. He is currently the director of SARS, which is Center for Technology Assisted Reconstructive Surgery, a startup company started in 2015 as first unit in India, which specializes in 3D printing, designing and printing of implants and guides for the dental, cranium, and maxillofacial region. Dr. John's passion is to bring the best in technology to needing patients in India. He is actively promoting the applications of 3D printing to the healthcare community. He regularly conducts CME and CDE programs on 3D printing in medical, dental, and engineering institutions across India. Having delivered over 200 lectures on technology-based healthcare professionals, we are proud to have you, Dr. John, here. So without wasting much of time, I welcome Professor Dr. Shanmuga Sundaram to deliver his live webinar now.
Thank you very much, Dr. Padmanabha Kumar. Good morning, everyone. Thank you, Man. Thank you. Dr. Padmanabha Kumar is a very good friend of mine, and I thank him and Massa University for giving this opportunity. And John is a close friend of mine, and we have been in batchmates right from our undergraduate days, and he is doing a wonderful work in virtual planning, and more than, I think, 2,000 cases he has done in this in a short span of 7-8 years, and I hope this is going to be a wonderful session. So what we will right now do is we will just share a case, and we'll show you how to go about with the treatment planning and how to go about with the diagnosis and treatment planning of this patient. So this is a 20-year-old girl who was complaining of deviation of jaw and difficulty in chewing. And By examination, you can just see there is a facial asymmetry which is very distinct. So on facial evaluation, the shape of the face was mesocephalic and facial form was mesoprosophic. And on frontal evaluation, you can see there is a deviation towards the right side. On profile evaluation, you can see the face is a concave profile with an anterior divergence. The nasolabial angle is normal. The mentolabial sulcus is quite shallow, and the chin is normal. The average mandibular plane angle and the lips were forwardly placed. If you can just see, there is a reverse overjet of -5 mm and a bite of 2 mm. It's a classical class 3. The midline was deviated towards the right by 2 mm. Whereas the facial midline was normal, only the dental midlines were deviated. So the molars were class 1 on the left and class 1 on the right too. Next slide, please. So this is what we used to do initially. We started with all those two-dimensional planning, the cephalometrics, which will only give you an anteroposterior and superior inferior readings, and with that we used to do our COGS analysis, cephalometrics for orthognathic surgery, and with that you will see the discrepancy in the maxilla and mandible, and then do our planning. So that's what we were doing for quite some time. After doing those analysis, we saw that there was a problem list which was summarized with concave profile, deviated mandible, facial asymmetry, dental midline shift, retrognathic maxilla, and prognathic mandible. So these are the frontal views of this patient and intraoral views. You can classically see there is a midline shift towards the right side. So when it comes to treatment planning, we were only handicapped with all those two-dimensional images, and with that we used to do our mock surgery, and with that we used to do our faceboard transfer, articulation, and try to do a mock surgery with our Elixon platform, and arbitrarily try to do the splint wafer and everything. So to a certain extent we had so much of problems with the conventional planning, but when we are shifting ourselves to the digital planning, the virtual planning gave us a really very good picture in a three-dimensional way, where we were able to analyze the discrepancy in all three dimensions, the vertical, horizontal, and the transverse dimension, which was very difficult in one go with the cephalometrics. Okay, right now I would like to ask John a few questions, like if we have to go with the virtual planning, what would be the requirement, John? Whether you will go for a spiral CT or a cone beam CT, what would be the requirement? Dr. John?
Hi. Hi, Doctor. You want me to share that slide, Dr.
Yes,
Shanmugam?
yes. Just the CT slide.
Dr. Mann, if you can give me access to share that slide.
Yeah. Okay, sir.
So I just need to share that presentation on.
Yeah.
I'm going to share screen. Share screen. Okay. Yeah. Can you see?
Yeah.
Can you
I
see
can.
this? Can you see this?
Yeah.
Yeah. That's a CT image. Which.
Correct.
So what would be the CT which you would require, Dr. John?
Correct,
You would require a spiral or a cone beam CT, and what would be the FOV and area of interest?
Thanks, Dr. Shanmugam, for the opportunity also. Basically, when we do a virtual surgical planning, a case like this, you can do a CT scan, which is the best possible way, because it gives you the entire field of view right from your cranium all the way up to the mandible. But if it's a CBCT, it's great, provided we cover the orbits as well as the zygomatic arch as well as the mandible at one go, because that's the only difficulty we have in a CBCT. Sometimes your FOVs are small, right? So you will only get one jaw particular. So if that's the case, then planning won't be very accurate. You need to get the whole thing in one shot altogether. So if it's a facial asymmetry, then CT scan. If it's just a dental change that you want to do, CBCT is more than sufficient.
What about the slice thickness? What would be the slice thickness which you would be interested?
The slice thickness has to be 1 mm or less than 1 mm.
Less
It's
than
very, very critical that we have it at 1 mm or less than 1 mm. Otherwise, you will end up having step deformities.
Okay. What would be the format which you would prefer?
These are
DICOM.
called DICOM formats, correct? So these
DICOM
are called
formats.
DICOM formats. Most of your scan data will give it to you directly there.
Okay.
And then you convert that into other versions like in STL and then start working on it. But then the data has to come in as DICOM format.
Okay. So how many CTs would you prefer totally during in that orthodontic planning, like pre-op? I mean, like for immediate.
Yeah. See, one CT scan would be sufficient preoperatively, and then
Okay.
for you to check that's it. Provided you're doing the surgery immediately. See, that's so. There is also a time gap. Many a times we get the data, and then the doctor does the surgery after a few months. So then there is movement which has actually happened. So CT scan just before the surgery, and then your dental scan also needs to be done. So that I'll cover it in my presentation also a little bit.
Okay.
And once we have it, and then straight away we start the planning on.
Okay. So in this case, like we all know it's a skeletal class 3. So how do you diagnose and how do you plan for this, and what are the tools which you will require normally for doing this diagnosis and treatment planning?
Okay. See, if you talk of diagnosis, then you will need a CT scan, you will need a dental cast scan, you will need clinical photographs. So once we get all this data and we have an initial information from the doctor, those data are incorporated, and then we virtually can plan it. See, the difference between virtual and conventional would be in conventional, yes, you go through a sequence of working. In digital, you have a 360-degree view of everything. Because you have a 360 view of the whole the defect and the abnormality, we are able to get a checklist of what the problem is. We are able to address the problem, sequence the problem, and if there are errors, we don't achieve the right final result, we always can change those. Unlike in conventional, you have to go through the whole process of re-articulating, demounting, baseboard transfers. All this is minimized, and therefore the errors are less in digital and virtual planning.
Okay. In this case, like you can how will you decide how much pitch, how much roll, how much yaw you want to do, like in
Yeah,
this classical
correct.
case?
So the pitch, roll, and yaw, most of the time the software does, the algorithm is already set. So we still have cephalometrics as our baseline. I mean, we don't change the conventional methodology because cephs still are the golden standard. But once you have a certain value, then you set your plane of occlusion based on your franco-horizontal plane, your occlusal plane, your mandibular plane, and then you decide how much of movement you want. So I'll have a couple of videos that I'll do when I'm running the presentation as to how we
Okay.
change the pitch, how we do the roll.
So do you have specific landmarks, like you have linear measurements, angular measurements, proportions, what you check?
Yes.
Okay.
Everything.
So you're
Everything
going to
is set.
show those.
Everything is
You're
set.
going to show those
Yes,
slides. Okay.
I'll show
Right.
those slides.
So the quantum of movement of pitch and yaw and roll will be depending upon those values, right?
Yes, exactly.
Okay. Now, how do you bring in the soft tissue into this prediction? Is there a
Soft,
possibility? Is there a
yeah.
role for
See,
soft tissue, or how do
yes,
you?
yes. See, so initially, so if you want to see a soft tissue again, based on, because the scan can also take in soft tissues, so you have an overall profile of what it is. Now, today we have the possibility of incorporating your photographs, so that gives you a three-dimensional view of how the patient would look. But soft tissue is only an approximation. No, it is not 100% accurate. People are working towards it. I mean, Dolphin is now moving a little bit ahead with soft tissue superimposition and prediction. But it's for us, from the way that we have done, for in our experience, it's only an approximation that will give you a value. This is how the patient might look, because there are a lot of factors that go into soft tissue changes, right? And we can't pinpoint them very, very accurate like we do that in bone.
Yeah. So what you're trying to say is sometimes the soft tissue may not follow the hard tissue.
May not, it may
May
not,
not.
it may not.
May not. But I think you have the latest softwares with you where you can evaluate the outcome of your orthodontic
Correct. Yes.
treatment. I mean, like surgery result also, right?
Yes,
Because
you
Dr.
can.
John has been doing that, I think, for the past 2 years with the new software where we are able to evaluate the outcome. Like we have the pre-op CT, then we do the virtual planning, then again we do the procedure, and then we take a CT. So there'll be 3 CTs where we'll be able to overlap things, and then we can just see whether we have achieved what we wanted, whether the goals and objectives have been achieved or not. We can evaluate based on that. I think here we are done almost 15 to 20 cases right now where we are superimposing the pre-op CT with our outcome CT, and we are able to see where we are going wrong and what is the error which we face. And to our surprise, John, the discrepancies are hardly less than a millimeter or so.
Correct.
So
That's
with
how
your
accurate
CT planning
we can
and
determine.
with the wafer what we have, I think the discrepancy is. And I'd like to reiterate one more thing. Whatever virtual planning we do, it's only a guide. So by doing a virtual planning, it doesn't mean that the results are going to be really good or
Yes,
bad, because it
exactly.
totally depends upon the surgeon's skills and his experience. So please remember that virtual planning will diagnose, will give you a guide, and will give you an idea how to go about with the surgery. And with that software and all those wafers, we'll be able to interpret what we want within the operation theater. The same thing what we have done virtually can be replicated within the operation theater. So that will be a real guide, I would say. Or do you accept with that, John? Or
Correct. Very true. Very true. See, whatever done, these are just tools. No
yeah.
matter how expensive you have, these are just tools in your hands. So you need to have the skill with you. That's very true, Dr. Shanmugam.
Yeah. So how did you plan this case? You had the skeletal class 3. I think you have done some beautiful color coordination. This case was, all my virtual plannings have been done by John, but this case was one of the earlier cases which he has done, which with beautiful demarcation. You can see the maxilla is demarcated in violet and the mandible in green, which is very self-explanatory. Even to show it to the patient, it will be very easy for us to explain things. And how did you go about with this case, John? Can you just give them?
So the whole thing. So the whole sequence is it's very well done on the software. So what you do is once we segment it, once where the CT scan comes in, we do a process called segmentation, and you threshold it, and then you divide the maxilla and the mandible all together. We start making the cuts, and then because you can color code it, because you also want to not just plan it, you also want to demonstrate for yourself as well as to the team how much of movement you want to make. So these color codings are done on the tools. You set the color codes, and then you start making your movement. So we depending on what the patient's complaint is, either the maxilla wants to go up or down, or in anterior posterior movement, we make the movement, bring the mandible also. Since it's a class 3, we move the mandible backwards to how much ever we want to move. See whether it's in right proportion. Like Dr. Shanmugam said, we have our pointers, point A, point B. You have the chin points, and then we also check it with reference to the condyle, whether the condyle is moving, whether the condyle is displacing. So a lot of things go on the software tool planning that you orient yourself. And once you've done it, and very true, the biggest advantage is we can also see post-operatively how it looks, and you compare it. So that's the biggest advantage in a VSP, that you can see where you are, which direction you're going to go, and the whole thing is controlled by the splint. See, that's that whatever you plan, you have to execute on the theater, right? So you have to take something on the table physically for you to fix this. So that's where the splint records all these movements and keeps it for you, for the surgeon, to make it easy for him.
Yeah. So to reiterate, he's saying wafers and splint, but John is right now moving towards waferless surgeries, where he is getting patient-specific implants. Where what he does is he does this. See, this case we did VSP, and he gave us intermediate splint and a final splint, and based on that we did it. The next step what we did was we started using cutting guides, but right now he is doing PSIs, that is patient-specific implants, where they move the maxilla and mandible, and they fabricate patient-specific plates, the implants, which can be just fixed there, and you don't need any wafer as such. You just go in, do the down fracture, advance the maxilla, fix the plate, which is preset, and with the screws and everything, and it's totally guided. So you don't have the hassle of making wafers as well, and you don't have that problem of having discrepancy with the occlusion and everything. So I think that's what we are looking towards, right, John, if I'm right?
Yeah, that's basically it, Chan.
So can you just show the next slide, the outcome of the slide? Outcome of this patient.
Yeah, sure. Sorry, I think I missed on that.
There's just one more slide, which
This is the last one. Yeah. Can you see this? Yeah.
Yeah, I will share, sir.
Yeah, can you share? It's not seen.
Yes.
Yeah, that's the patient, same patient, which
The
you
case.
can see that facial asymmetry is corrected. The midlines are symmetrical. The facial midline is symmetrical with the dental midline, and I think the virtual planning played almost 90% of the role, and I think the surgeon's work was only 10% in this. So it made a lot of difference with the planning and diagnosis with the softwares and getting the ultimate result. I think John would agree with this. I think this is
Good.
what
Yeah.
you can really achieve with this patient, right? You can see the
Yes,
profile is
absolutely.
orthognathic right now. It's a straight profile with a normal mentolabial sulcus and labial fold, and you can see it's the occlusion is in class 1. The midlines are symmetrical. I think patient should be really very happy with this, and her deviation is also corrected. Right. So thank you, John. Thank you for this help with what we are with your help what we are doing right now, and I think John will take over with this presentation. Thank you.
Thank you, doctor.
Thank you, Prof. Shamuga, for presenting your cases. Thank you for the great discussion between both of you.
Yeah.
I'll ask Dr. John Nissan to present his slides.
Yeah. All right. So I'll start sharing. Okay, guys. So how much more time do I have now, Dr. Man?
Time now is 9:25, so may have 25
okay,
minutes, sir.
Super. Okay. Okay.
Yeah.
Can you see this? Let me know if the slide is moving. All right. Guys, good morning. I'm Dr. John. So my presentation is going to be on applications of 3D technology in dental and CranioMaxillofacial, a face changer. I would like to thank Masa University and especially Dr. G.B. Padmanabha Kumar for giving me the opportunity. We've known each other for quite a long time, and thank you for the opportunity, Doctor. Can you see the slide moving, Dr. Man?
Yes, sir.
Yeah. Okay. So
Yes,
I'm
sir.
Dr. John. I'm also the director for
Please proceed,
STARS,
sir.
and let's go on into it. So today, what is extremely important for us is, like we all know, see, beautiful faces. In a field especially like ours, face is an extremely important thing because that's what shows us to the world. And every face has a certain algorithm which is already preset. That's what differentiates between one person to another. Okay. Now, this face is very important for our identification as well as that's what our uniqueness is. Okay. However, you may be, that's your straight identification. But this identification sometimes can be lost because of trauma, because of pathologies, because of a congenital defect that we may have here and there, and because of aesthetic and functional issues. Now, when this uniqueness that we have with each other and this identification is lost, then we have a problem. Now, the way of restoring this is what is very, very critical. If you look at this about 100 years ago, people still were doing whatever we are doing right now, but it was science. It was purely science experience. People would be there for a surgical procedure or for a meeting. No, you understand. But today, all that has changed. Science, along with technology, is playing a very, very big role today. Now, we are not. That's what I'm saying. No, we are not stopping science. Science will remain the same for the next 100 years. But with technological advances, our role into using science and how well we adapt it is changing. So I'm going to, this saying is very, very true for us. If we all worked on the assumption that what is accepted as true is really true, then there is very, very little hope for advances. So you constantly keep asking, how can I make this better? How can I make things how can I improve the way I'm going to operate? How can I make my life better? How can I, see, that's our constant pursuit, right? Today, we want to travel better, we want to eat better, we want to live better. So similarly, we also want to do our procedures for our patients better. That's advances. So the technology that I'm going to present is it's not a old technology, nor is a technology which like a unique technology which is going to start and then going to end up. We're talking about 3D printing, which is on for the next decade. This is going to be one of the top technologies, 3D printing, along with artificial intelligence and immersive media. So I'll show you a little bit of that and what we do in those things. So the way we operate and treat our patients is changing. Whether you believe it or not, I'm basically here going to tell you, boss, why don't we upgrade ourselves? Okay. Now, so change is inevitable. I mean, we all will agree that change is inevitable, but growth, whether you want to come on the bus, whether you want to decide that you want to change and you want to grow, that's an optional thing for you. So I'm here to say this is innovation. Now it's today people are talking about innovation, practical implementations. How can we make things better? So that's always going to keep on happening and happening. The way for growth is when you constantly innovate in very simple things. You don't have to discover the moon or the star. In whatever we are going to do, if we can make a small thing, we can discover something, or we can see how best practically we can implement it. That itself is a big innovation, and that will go forward too much. Now, so one of the biggest in the last innovation in the last, like, I would say 20 years is the science of additive manufacturing or 3D printing. Because whenever we talk of 3D printing or additive manufacturing, the question is what exactly is it? Everybody's talking about this. People are this is actually now today becoming very common now. It's not new. It's a 30-year-old technology actually, ever since 1983 that it was discovered by Charles Hull. So now only we are seeing the benefits of it because the applications of it are more mature today. So 3D printing or additive manufacturing is actually a process of making three-dimensional work from a digital data. Okay, you take a physical product based on the data you used to get. We always would had CAD CAM is already there, but then what happens is because of the complexity of the objects, we could never design it or we could never have a physical product unless it went through a certain methodology. But because of 3D printing today, whatever you design, whatever you have the data, you can have a physical product today. So this is basically a video which shows you as to how we 3D printing moves. I'll run it very, very fast so that you have an idea and move forward. So it's basically layer on layer that it forms. And once these layers, any shape that you want to do can be determined by it. So like you say, this is a layer, the second layer, third layers. So the more layers that are being formed, ultimately you have a product. Okay, so that's the advantage as far as 3D printing goes. Okay, 1 second. Next slide, please. So what are the different methodologies in 3D printing? You have something called as FDM, fused deposition moldings. We have polyjet machines. These are different machines and methodologies and sciences in 3D printing. And you have like stereolithography. This is very common for dentistry. I mean, this process called DLPs or SLAs, because this is pretty affordable and each one of us can have them. And direct laser, if you want something in metal, then you have this process called it metal laser sintering, which you have very high-end machineries where we can print actual metal as such. I mean, titanium, chrome, cobalt. So different materials are being used today to 3D print. And finally, 3D bioprinting. I mean, I think we are going to be looking at, maybe not now, but I think the next future is going to be how we can print our own body parts based on our own cells. So that's a science which is moving forward. And definitely, yes, there are a lot of big advantages, big innovations that have been done with skin, 3D printing of skin and in ear. And India is also not very far behind with respect to 3D bioprinting. So why is this 3D technology moving forward? This is just an introduction, so that just another 2 minutes and then we'll go on to the application. It's moving forward because of improved diagnostic tools. I mean, like Dr. Shanmugam said, CT scans. I mean, when we were doing a PG, that time CT scan, the minimum slice thickness used to be only 1 mm. Today, I can do it at 0.6. We can do a CT scan, CBCTs at 0.3. Today, you have micro series, we can do it at 0.04. So we can, as thin the slice becomes, the more smoother the end product is. Today, you have lab scans, you have intraoral scans. Those are becoming a big game changer. Number two is going to be VSPs. Virtual surgical planning is the biggest changer which is bringing the world together. This was only applicable in certain universities across the globe, and therefore only they had access to all these tools. Today, because it's commercialized, because the cost is coming down, every one of us can get access to a virtual surgical planning. And finally, whatever you plan, you have to bring it to a product where you can use it. That is the game. I mean, you can see beautiful things on your screen, But if you're not able to get the same data and use it in your practical in your dentistry or in your surgery, there is no point in it, because the transfer of visual perception can change from person to person. How exactly you are bringing it is where virtual surgical planning is. So what are the tools that we use? Intraoral scanners. You have a big array of intraoral scanners today, ranging right from, today I think the lowest cost has come down to around 6 lakhs for an intraoral scanner. In Indian rupees goes all the way up to 22 lakhs. Then we have lab scanners. So these are all your armamentarium that you need to have. Okay, then we have software tools. Softwares are playing a big role today in 3D printing and in virtual planning. So you need to have a software for converting DICOM to an STL. I mean, there are free versions, there are paid versions. You can choose whatever you want depending on them, and most of them are equally good. Then you have CAD softwares if you want to design something, and then we have VSP softwares on our own also. So today, orthodontic as is becoming a big branch today, and because of the concept of VSP and how useful we are going to make it, and finally 3D printers. So where do we use it in dentistry and in CMF? We use it in three different areas. One, as a diagnostic tool, which the whole world actually does it, not for you to see something, visualize it, and then okay, identify it. That's one. Where the world is moving on is into planning. Okay, now this is where it is becoming a game changer today. As we start planning better, then we have good tools which we can plan and therefore make minimal mistakes. So where we always would differentiate from the West would be is their planning was good. Even when I did my fellowship in Germany, and the Shanmugam also, I mean, when you go abroad and you learn, you realize that the West plans better. They spend a lot of time planning. Therefore, the surgeries are much accurate and much faster. And number three would be as a treatment tool, because not just in plan, you also need to bring those tools. Can you treat them? Can you use 3D printing as a final end product? Can a product that can go into the body? Can a part that can be used to replace, and can it be a part that can be used for treatment? That is where we are moving forward to. So I'm going to look at different specialties and what we want, just a short presentation in each, and then see where we use it in each one. As far as prosthetics, we use it a lot for 3D printing metal bridges. I mean, this is common. 3D printed temporary crowns. Now today we have come to a state where if you have a small 3D printer in your lab, in your clinic or in your practice, all that you need to do is you scan one after your crown cutting is done, take your intraoral scan, use a very simple software tool to do your temporary crowns, and then just send them and press a button to print it. Today you have good resins which can make 3D temporary crowns in a matter of, I think, 3 hours. Okay, perfect. Three to maximum 3 hours is what they take for you to print a temporary crown and give it to your patient. Okay, yes, you can do it much faster with your lab, right? But how accurate can it be? Okay, so that's where 3D printed crowns are. And number two is in cast partial frameworks. This is becoming a big game changer in my circle that we see in my cast partial dentures are 3D printed today a lot. And 3D printed dentures as such have come into play. They're not very extremely useful as such for a lot of things, but there are slowly people are making movement as far as the 3D printed dentures, because the problems that we faced when we started doing complete dentures in 3D printing was actually the vertical dimension and the fit. No, you still would need some manual effort into it. So we didn't move much into that. But as far as your crowns goes, as far as your cast partials, big changes. Orthodontics, I mean, we all know where orthodontics is going as far as 3D. It is truly becoming a game changer in orthodontics. Today, you have a lot of people talking about in-house aligners, in-house splints. Also, the biggest change that we have, one, is in the form of alignment of teeth today, not just with braces, but also with the concept of aligners. Ever since the USP of the Invisalign started expiring, everybody has access to making an aligner. In fact, actually, if you have a good software tool and you have a good orthodontist sitting and planning, you can make your own set of aligners for your practice or for your group practice. It works out extremely cost effective when you 3D print them yourself. And also lingual orthodontics, I mean, because for you to plan that better. And this is something which we found was a very useful tool. Is already there for indirect bonding. In an indirect bonding, you will find how easy it becomes when we use a 3D printed software tool. Okay, you make a model, you mark it on the model, and then all that you have to do is start making accurate brackets. Once these brackets are on, it's a matter of you placing your brackets onto this tool, positioning it in the right way, taking it on the mouth and curing it, and then you're done with it. But whatever, dude, I mean, where this is becoming a big bane or a big flaw is when non-orthodontists start using this, then this becomes an issue. So in my case, it needs to be done by a specialist. Don't even try to do it if you're not a specialist. But if you're a specialist, then your life becomes much easier. Use these tools with the help of a proper orthodontist along with you, and it makes your life much easier. So once it's fixed, cure it, and then you're done with it, as far as the bonding goes. So this becomes, I think, a pretty faster way of doing. But we have tried this. It works actually like magic in the orthodontist hands. So that's one. In conservative dentistry, I see it being used in 3 different positions. One as a study tool, one to create endodontic access, and one in surgical case. So we regularly get work from Meenakshi dental colleges, and one, I think 2 and GDC and a couple of colleges here, as far as for endodontic access. One as a study tool, it's very useful for you to make and to educate a patient, as well as to show for yourself and the group as to where my problem is and how am I going to treat my patient on. That's number one. So if you see it, whatever we plan virtually, see, we know where the pulps are, how the chamber is, and how we're going to access it, whether there is a canal there is no canal there, spaces in the pulp. I mean, I think conservative dentistry is an endodontics especially, is going a little notch higher as far as 3D designing and technology goes, because I see a lot of R&D with respect to 3D designing. So we can print whatever we want to print on that, check the model to see where we are. So as a diagnostic tool, it's proving itself. As an endodontic axis, yes, so you can make conventional endodontic guided endo accesses with 3D printing. So this gives you a small guide. This is how the planning is done. So, okay, in case you have a narrow canal or you have a curved canal, you want to access it, you visualize it in 3D and make a simple guide like this, where all that you have to do is just get into this and get it done. So this is how we do it. I mean, I personally don't do these guides. I have my team of doctors and engineers who sit and work on it, because the time taken for us to prepare a guide for an endo is very similar to doing it for a surgery. It is time consuming, but I think the level of accuracy is actually proving to be very good for a lot of endodontists. So that's a plan. Today you have guided endo sleeves also. Those can be also used as an option. And in case of a calcified canal, how you use it, how can you access it. So this is how, these are all actual cases done by doctors with help, with our help, kept the guide, and then straightly with the guide you start accessing them. And I think even this came in it won one of the best paper awards or something for micro guided endodontics. So endo is also becoming a big role. And surgical guides, when we make surgical guides for your RCs, you don't have to, you know where the pathology is and how you want to access them. So we make the mark, like this is a case from GDC in Chennai, where you, once you know located where the pathology is, you make the mark, slow mark over there. We did a 3D model just for us to see how accurate it is, and then you raised in this, because it's the first time they were using it, we actually raised quite a large flap. But conventionally, you don't have to raise such a large flap. You just have to make a small C-shaped incision and then go into the problem, go into where the pathology is, clean it, irrigate it, and then if you want to do resect it, get it done, and then we can come out. An extremely conservative way of handling for surgical guide access. So that's the way the guide decides, and see how precise it can sit on the location that we want. Not just for anteriors, even for posteriors that you want to do, it is pretty useful over there, and also for conducting endodontic courses. It's not actually about an idea, it's about how you make the idea. So most of these applications are in collaboration with doctors, and I think for me, Dr. Shanmugam has been an asset to us, because he's been using the software tools and planning right from the time we started. We started in 2014, and right from 2014 they have been, SRM Dental College and Dr. Shanmugam has been in constant support of us. So you have to start using them. Another big use is in the field of dental implantology. Now, in implantology, the digital workflow is actually very different. For you to scan, plan, manufacture, and deliver. Okay, you can make 3D models. 3D models. So these are the models that you have. If you want to do a training program, you can make 3D guides and splints. So this is how we make our guides and splints that are kept over there. I mean, actually, the implantology itself is a separate lecture altogether. So I'm just running through them to show you how the guides and the splints looks. Bone cutting guides we can make. You can trim them. So these are all the applications that we have for in implants. Not just in implants. In case you want to do a, let's say a pilot, you want to do a all-on-6. How accurate can this become? See, a guide makes your job very, very easy when you have it flapless. So most of the time, this for us took us maximum about 15 minutes for us to place this, because all you have to do is position it and then close your eyes and place your implants. So now pterygoids have always been a challenge. So how do we access pterygoid? Again, with guided surgery and planning. So this is how the guide looks. So you see how the angulation is. Place it on the guide and then you start drilling it and then you're done with it. So today we're moving on into we have collaborated with Zimmer. And so with Zimmer, we are actually making guides for Zimmer as well as a couple of other implant companies where we can make and plan better. So this is one of another example of how we use our implant guides for you to make to you to plan your implantology. Not just conventional implants, even if you want to look at advanced implantology like zygomas and pterygoids. So classical cases were this with Dr. Johnson Raja, where you have to place a conventional implant, a zygomatic implant, as well as a pterygoid implant. So how do you plan that? Yes, so that's how you plan it. Once our planning is done, that's the guide that we made. Once the guide is done, and that's the implant, the way it was positioned, and that's the post-op. So exactly how you plan, your post-op will sit, okay? And narrow ridges like this, done. Not only that, today you can go on into placing zygoma, quad zygomas. I mean, you have quads and then you have penta guides also can make. So the guides are placed like this. Once you position the guides, place your implants, and that's a post-op X-ray. So the guides are done for zygomatic implant also, which makes your life easier, but also then you have to raise your flap. What do you need? Like Dr. Sharma said, first you need to have a CT scan. Once the scan data is done, then the intraoral scan is taken, and then you start planning it. Digitally, you work on what you want to do. The plan is decided, sprints are done, and that's how you position your implant. So how does the workflow go? You have a 2D to 3D conversion, then your implant placement is done virtually, then your final plan, and then a sprint is done. Orthognathic surgery. So in 3D printed guides and sprints, are they really useful? I'll just show you one video as to how we use them for a class 3, like Dr. Shanmugam was saying. So when we get a patient like this, how do we start taking it forward? Okay, so you decide where you want to do. Do you leafward cuts, and then you advance the maxilla. So this is how once the advancement is done, and then whether you want to impact. So you have this option that you do. How do you choose? You have to choose based on your cephalometric plan. So we definitely would need the scan data, but then here, because you're seeing 360-degree angle, you can plan much better and work out much better. Intermediate sprint is done. Your BSSO cut is done. Once your BSSO is done, the mandible is also moved to set back how it is. And once we got the final position, and then the final splint is being placed. This is how we do it in planning, and then that's the one case that we have. Just a show you of a case of how we do it for a class 3 patient. I mean, Shanmugam showed it, but here I'll show you how we use the cutting guides also. So we used a leafward cutting guide, made the cuts, did the final splint also, and that's the pre and the post of the patient. So how do we use VSP? What all can you do in a VSP? This is how you can see how you can use the VSPs. So you can make an anterior posterior movement of the mandible that you want to do, superior impaction, and you want to do a grafting. So all these angles are being done in your VSP. So once we do all this, guess where? So you have an entire plan of it, and all your planning. If you want to do a counterclockwise, and you'll be very surprised how much of corrections that you can do on your VSP. Your corrections, facial asymmetries. Once we do this, then position it in the best final position, and then you go ahead and you finish your work. So choice of images becomes very important. Data acquisition, whether we're using a DICOM and intraoral, patient workup, VSPs, and surgical execution. So facial asymmetries, okay, even complex cases like facial asymmetries, you can start planning it with like this. Cut off the condyles, cut off the planning, start working on this. Once your plannings are done, and then you choose the best possible option and start working on it. Okay, and this is what we do. We do custom-made frameworks for leaf 4. For us to now, we've gone like these are called splintless surgeries, guideless surgeries. So once we do the virtual planning, instead of you having a intermediate final splint, you can actually 3D print your framework all together and position it. Makes life much easier, but it is still on the expensive side. But then costs are coming down also. So in maxillofacial surgery, where do we use it? This is for a how young can you go? This is for actually a 6-year-old kid, which was done, which had a cranial tumor dysplasia. So we had to remove this kind of a bone. Once we removed the bone virtually, this is how the patient looks actually digitally. So all this is digitally done even before you see the patient. Remove that, plan the implant, and the problem with this is because it's a growing kid, right? So how do you accommodate? So we actually extended the design so that it can accommodate for growth. Secured the screws. The doctor secured the screws only on one angle. In the lower portion, didn't secure because as the skull expands, then obviously you're compensating for growth. Made a guide so that you need to cut in the exact area. See, because when you do a customized implant, what is very critical is that you also have to have a guide, because we can't cut in any way and then make the implant sit. It has to be in a very proper sequence. Made the cut. That's how the customized implant looks like. We did it in two different movements or two different pieces because both sides, how you want to compensate for growth, it can grow. We are actually looking at this, changing this probably when the kid is about 10 years old. You change this and then you can make another PSI if you want to make a PSI. That's the cutting guide. That's the implant. Another case for a patient who had a right maxillectomy done, and then how do you replace for mucor? Because mucormycosis is a totally debilitating disease where you just don't have one bone loss. Okay, in this patient you had floor of the orbit going, you have the entire maxilla going, you have part of the zygoma is gone. How do you restore these kinds of patients? Now, and how do you do it at one go? Yes, microvascular is still the golden rule. I'm not saying no, but then with 3D technologies, we can restore it as accurate as possible and as fast as possible in one procedure altogether. So we virtually planned it, we mirrored it, saw how much of bone loss that we have and where we need to compensate. Once we got that done, designed the implant accordingly, mirrored it to see that it's not bulging too much, got the angle. See, all this is only because of 3D printing. Because you can go to the lateral wall, you can go to the zygoma, the orbital floor is compensated, the maxilla is compensated, and the dental components is compensated. So you're doing almost 4 to 5 works in one implant itself. So that's the implant that is designed, and that's the PSI that was manufactured. Opened it with a Weber Ferguson, and that's the temporary denture that we gave the patient. I think about 2 weeks after the surgery, we gave them a prosthesis, and that's the PSI. So this is how we looked pre or before the surgery. This is how we looked after the surgery. You see the difference now? This kind of bulge that gives in, that's the implant that is provided. And this was again for a young patient who had gigantiform cementoma. The entire bone of this patient is lost. So we just don't lose one part again. A very severe case, very rare, 1 in a million. This is where the entire maxilla, orbit, zygomas are also gone. So how do you replace bone for a kid like this? So when this came to us from Government Dental College Chennai, I think an amazing group of people who do awesome work from there. So for our job is to only do a 3D model. So we said, sir, can we give something more for the kid? So we took a model, we did a virtual planning, removed the bone before the surgery, superimposed it with a skull of a growing kid. This was an 11-year-old kid who came to us when they bought the scan. We superimposed the 15-year-old kid, compensate for growth, did the design on the patient. Once the design is done, compensated it in a way which you can have the framework done, because once you remove the bone, what you realize is the whole face is going to fall flat. And there's nothing supporting his nose, nothing supporting his eye. So you need to compensate that when you're doing your PSI. So a PSI is not just a small plate or is another recon plate. No, it does much more than that if you plan it well. So that's how we did our model mock surgery. That's the implant over there. If you see, it replaces your orbital floor, your maxilla, your zygoma, as well as you have a dental component there with teeth. So that's Dr. Arun and his team over there from the Government Dental College Chennai. That's the surgery that was done. Can you see this? This is the only thing that's holding his face. Without this, there's no face at all for him. So thanks to technology, that's what the lesion that was removed, and that's the patient's face before surgery, and that's him after surgery. So we have a 1-year follow-up on this. Now, how much more do we have? Alive. This is another patient for classical for atrophic macular. I mean, this is a patient with chronic periodontitis who came in. So what do you do when you can't do dental implants? Okay, you can't do conventional implants. What do we do? So this is a case where we did an extraction, place the cutting guides. So we did what is called as custom-made frameworks. So you have a position where you can design frameworks to rehabilitate atrophic maxillas and mandible purely based on patient's data. So we did that design, got the patient restored with that, did these frameworks. Now this was done actually 2.5 years ago before COVID, and now the implants are becoming much more sleek and thinner. Gave the denture to the patient during the surgery itself. So we have come to a state where we can, when the patient comes, extraction, surgery, and teeth at one go on the same day. Once we've done it, this is how the implant is actually looking for it. And then we said after 2 years, the patient wanted to change the processes, took an impression again. So this is how we take an impression, did a jig, did the bite registration, and then gave the patient as zirconia prosthesis. So that's a happy lady over there. So all this is possible. Another case where we can replace it. So today, 3D technologies, you can do awesome things. So maxillary reconstructions, so mandibular reconstruction, sections of reconstruction if you want to work on. You want to work on a joint or total joint replacement. I think this is becoming the big game changer today with respect to ankylosing patients, facial asymmetric patients, and a lot more can be done with 3D printing. So not just that, today I've said we are moving on into AI and into VR. So with virtual simulation, today our visualization is becoming better. Okay, you can plan, you can see the patient, see the anatomy in virtual simulation. Not just that, we are moving to a stage where we can do our cuts and we can start planning in VR. Even so, let's say you want to consult with another surgeon in India or any part of the world, all that he has to do is have a VR set, and you can be in the same room and same Zoom and start planning it. So that is
Very,
there.
very
And
interesting, Dr. John.
Superman.
Thank you so
So
much for the information or sharing the cases, sir.
yeah, okay. I'll just run this
Yeah,
once.
I think
Okay.
now our audience have very great idea about the applications of 3D technology and digital technology in general dentistry.
Super.
I'd like to ask you, sir, about how precise is the virtual planning for implant placement?
Dental implant placement.
For dental implant placement, yeah.
I think it's, see, the how precise, it's 100% precise. No,
Okay.
Yeah.
but
Yes.
okay,
Yes. Yeah. I'd just like to add on that. Like, I have been
Yes,
working
Prof.
with John
Sham, go on.
for almost like we were working together like almost like 15, 16 years right now, I would say. So we used to get those guides from Sweden and US 15, 20 years ago. Okay, and in spite of getting them from there, and what happens when we try it on the patient, it immediately it warps and it doesn't fit. But what I have seen with his work, first time when he did a guide and gave us, it was picture perfect. It was 100% perfect. Like there was no error in the placement as well as, that's what I said. Like you can always, you can evaluate, you can go back and you can do a repeat CP, you can do a CBCT post-op the surgery, and then you can evaluate your outcome. Do you understand what I'm trying to
yeah,
say? Like you have your pre-op, you have done a virtual planning right now, right? Then he gives you a guide. You take your guide, you place the implants, then you do a CT, post-op CT. You compare the virtual planning with your post-op CT, right? And you can see the difference. It's almost less than 0.05%. I think
Oh,
it's precise. It's
that's
too
precise, yeah.
precise, and it's unbelievable. First time when we saw it was really unbelievable. So that's what we try to improvise ourselves with all those softwares. And there was another question which was asked whether virtual planning can go wrong in reconstructive surgery. See, I would like to repeat what I said earlier. The VSP, it's only a diagnosis and a tool, right? the outcome, it totally depends upon the surgical skill of the surgeon. Just because you're doing a VSP, that doesn't mean the surgery should come out very well. Please understand.
Yeah,
It might
I'll
be,
add on to
yeah,
this.
he has shown some complicated cases. Okay, those cases like that cementoma, gigantiform cementoma, and all those mucormycosis. Not everybody can do that, and including those zygoma implants and other things. Not everybody can do that. So you need to have that surgical skill as well as experience. It's a learning curve with the difficult cases.
Very
Like if it is going to be a basic implantology like single tooth implant, it's going to be, it cannot go wrong. I can say that. But when it goes to 6 to 8 hour surgeries with all those reconstruction and PMJ things, you need to have those learning curves. So, and at the same time, you need to sit with John or his staff. His staff are too good, I'll tell you, they are well trained, and for all they have done more than 2,000 cases right now. So you can see what kind of experience they will have. John has shown you the entire spectrum of usage of VSP, like right from starting from dental endodontics to implants to reconstruction to TMJ, orthognatics, everything has been covered. So you need to sit with the staff, you need to sit with them, discuss. For example, we did a TJR, we did a TMJ reconstruction. So there was almost 2 hours of discussion. They just sit with the staff and discuss the design, the outcome, the material, everything is being discussed. So if you sit and discuss, I don't think there's going to be any problem with the outcome of the surgery.
Yeah, thanks,
You would
Dr.
like to add
Shanmugam.
something?
Thank you.
Yeah.
True.
You would like
No,
to add
true,
something?
very true. See, because planning is very important, and also I'll address your first question. With respect to implant guides, you can do an awesome plan. See, there are a lot of softwares which do. So it depends on which software you plan. Number one, in which material you're going to take the guides out. Initially, we used to take it like with an FDM technology. The accuracy there is very poor. You can have a printer for 50,000 Indian rupees and still print guides. No, it doesn't make sense at all. It will not sit. So there is also obviously the choice of materials are there, that which technology you're going to use. And very true, like Dr. Shanmugam said, whatever said and done, you need to get your hands wet. Your skill has to be there. There is a learning curve, even for implant, for virtual planning and for implant placement. Even if I give you the best tool possible, you need to know how it's to be used. But once you get used to it, which is a very short learning curve, we don't have to go sit with big doctors, go abroad, get trained. No. Sit, have a very short learning curve, and then you're good to go with anybody else, as
Yeah,
good as anybody else.
I still remember, like when we were in the early stages, I used to go to his office in
Correct.
Santom. We used to sit together for 1 hour, 1 or 2 hours, and spend time in planning right from the beginning till the end. So that those I see. I was very fortunate that time to have John in Chennai, so that I was able to go there in person and see him. But right now, since you have this virtual media, you have the Zoom and all those Streamline or all those, you can always discuss your case with him, and then you can do the diagnosis and planning, and you can do all those wafer fabrication and all those things with him. It's really interesting. You need to sit for one case and see how it works out, and you will see the outcome yourself.
Sometimes the total plan also changes on the table, right?
Yeah, you
It
should
can't.
go with the plan
It
B
should.
always. Plan A,
Yeah,
plan B. You
there
should
should be
have two
always a
plans,
plan
right?
B.
Yeah, plan. There should be a plan B always. So, see, for all like we first time when we did the OGS case for a conference, he offered us to help us with the mandible advancement. I still remember the BSSO. That was the first time he offered his services to us, and so because we were new to VSP and we didn't know anything, so we were having certain glitches. And the best part with John is he or his team members, they come for the surgery. That is the really a best thing, who has done the planning and the fabrication of the wafer or the prostheses, the part of the C-Star team, they are in the operation theater with us, so they'll be helping us. So if there's any discrepancy or any difficulty in placing the implant or the wafer or thing, they'll just guide us where the problem is, because they have done the planning. They know what's happening in the patient. So that's the best part. So he will guide you through the entire process. So I think it's John.
Yeah,
I think I would say you're a real asset for
yeah,
us,
of course.
and
Yeah,
and For every
Yeah,
year we do some kind of research study with him, and he's all the time ready to help us in any way. So I think even you should use all his services.
Yeah, GPK has to provide us flight ticket every time we want to come.
Sure. Hopefully, we'll conduct.
So,
a
yeah, I
workshop.
think this lecture will open our mind for good collaboration with Dr. John Nissan and his team for 3D technology and collaboration with the Malaysian dentist. Maybe for later, you want to communicate with Dr. John, maybe through Dr. GPK.
Yeah, we'll conduct. Hopefully, we'll conduct a workshop.
Connect people, yeah.
Yeah, we can.
Yeah. I think there are no more questions from the audience.
Okay.
Great thanks to Prof. Dr. Shanmugam and Dr. John Nissan for accepting our invitation for conducting the webinar. It was so informative and so beneficial. Appreciation from Faculty of Dentistry at Massa University for contributing to our webinar series.
Thank you,
Thank you,
Thank
Dr.
you so much
Mann.
for Dr. GPK for liaising with the speakers.
Dr. John Nissan. It's a early morning for them from India, actually.
Yeah, it's 7:30.
Yeah.
It's 7:30 a.m. Yeah. Wish a Merry Christmas to Dr. John Nissan.
Thank you, Dr. Mann.
Advance wishes, and wish you all a happy New Year too. Advance wishes.
Happy New Year.
Wish you guys
Thank
all
you,
a
Dr.
happy New Year.
Padmanabha Kumar. Thank you, Man. Thank you, John. And thank you for the wonderful opportunity.
We'll send the e-certificate through mail later.
Yes,
Thank
please.
you.
Thank you. Thank you very much.
Okay.
Thank you so much.
Thank you so much. We'll conclude this session. Thank you so much for the audience for listening to this session. We'll see you in next month for another webinar. Yeah. Thank you so much. Have a nice day, everyone.
Have a nice day.